Thank you all. Thank you, everybody, Jackie, and all the organizers for having me. I think this is really an important topic for us as pro-life Christians, Catholics, and just plain old pro-life people to understand a whole lot better. And I hope you all will walk out of here with an understanding of things that you may not have known much about before. I titled this My Life as a Pro-Life Neonatologist in a Culture of Death. And I think that is where we're living, but I think it points to a number of much bigger and much larger issues that I'm going to allude to as we go through the program here. The program I'm going to knit together is going to be several different stops along this agenda. So I'm going to talk a bit about my journey down this road, talk about the ethical landscape that we've currently created and we're living in now. And that's been going on for the last at least 50 years. We'll talk about prenatal diagnosis for sure. And prenatal diagnosis in the context of medical complexity, disability, and making it clear that someone you know will be affected by prenatal diagnosis, especially the younger folks in the audience. We're going to talk about our worship of our autonomy, our aversion to disability. We'll talk about acknowledged dependence, a concept that Alistair McIntyre was very well known for promoting. So something that we, even as non-believers, might be able to take away and say that we have a duty to support people not only with disability, but with medical complexities. We're going to talk about what should be the proper Christian Catholic approach to prenatal testing and the results thereof. And then what can we do now? I have some ideas about that, as you might suspect. So a couple of points to start with. We are dependent creatures. And that is not a fault of our species. That is an advantage. That is a benefit. We all require other people to reach our full humanity. And we may not always believe that and understand that. And some understand it better than others. But it is a fact. And other species do not have this power that we have to support each other and to give each other this support for relieving our dependence. But we need to recognize this. And I think it's especially important that we recognize it for folks who are not Catholic, who are not Christian, who may not have the same faith base that we do. I think we need to think about disability in a couple of different ways. You can think about it sort of as a medical complexity kind of issue, but it's also a social issue, and that gets into social cures and things like legislation. It also is something that might lead us to talk about sort of this reductionist view of the spiritual and corporeal. If you don't have that basis and that foundation, it's pretty easy just to start looking at others as corporeal. And I'll tell you right now, I don't think, and I hope, and most of us here in this room, don't define our humanity based on our ability to reason. And then we need to distinguish our vulnerability as not the work of specialists, but the work actually of each other. So what about people who are secular dealing with a person with disability? Why should they even care to support or spend the time to help folks like that? Is disability tragic? I guess is the big question. And we are so averse to tragedy that we oftentimes look to eliminate tragedy. So the answer for many without faith is that we would eliminate these tragic individuals. But the fact is, disability is a fact of life. We are all disabled to one degree or another. And we are all vulnerable to one degree or another. And you may not feel vulnerable right now in this room, but I could tell you my mother-in-law right now who's going into hospice is very vulnerable. I can tell you my daughter with Down syndrome right now at home who's 25, going through Down syndrome regression is very vulnerable. I can tell you right now my wife who's sort of trying to offer support for these folks who need and have dependence right now, she's vulnerable. We are all to some degree vulnerable. And it's important that we try and understand that in order to retain our humanity. The passive offering of Christ to others really should only support what we would do for other individuals. So when Christ came to us as religious folks, we should be able to look at the cross
and realize the ultimate vulnerability and what it should mean for us as Christians and as Catholics. So the bottom line is we're all disabled and we're all vulnerable. So for Catholics specifically, we have this belief that we're all created in the image of God. And hopefully that would be enough to develop and make available the support for people with disabilities and complex medical problems, even picked up on prenatal diagnosis, to be available. The fact is that we know that that is often not the case. We live in an imperfect world, okay? The disabilities that we see, the medical complexities, the chromosomal disorders we'll talk about, I think as Catholics, we understand and believe this is not retaliation or punishment from God, but it is a result of our fall from grace. It is a result of original sin. And we left ourselves open to a vulnerability which we would not have had previously. And in order to move forward, we need to recognize that in those who we, for whatever societal or cultural reason, have decided are more vulnerable or maybe less productive or maybe less useful to society. These individuals actually, for us as Catholics, offer us the opportunity to really expand our ability to love. And what we see on the cross is the ultimate gift of love. So a couple of quotes which I think are really insightful and really powerful to me. Pope John Paul II, this was his farewell address when he left the US. He was at the Detroit airport flying out after he was here in 1987. Every human person, no matter how vulnerable or helpless, no matter how young or old, handicapped or sick, useful or productive, is a being of inestimable worth, created in the image and likeness of God. And the Catechism tells us similar things. The poor and the afflicted are the object of a preferential love on the part of the Church, which since her origin, and in spite of the failings of many of her members, has not ceased to work for their relief, defense, and liberation. It would really be a defect, in my opinion, of understanding to assume that being created in the image of God is only revealed in the human person's ability to reason. This notion that we can define personhood is something which is anathema to the Catholic faith. All of us is body and soul, all of us. And despite attempts to try and separate those two things, that is what we as Catholics and Christians need to wholeheartedly believe and go forward in the world with as we raise the flag for those who are challenged with medical complexities and with disabilities. But that is not necessarily where we are at. So how did we get to this place? This is a quote from Helga Alfstadter. She works in Reykjavik in Iceland. Iceland is very determined to reduce the incidence of Down syndrome. I think there's only one way to do that right now, and that is through abortion. But we don't look at abortion as a murder. We look at it as a thing that we ended. We ended a possible life that may have had a huge complication, preventing suffering for the child. And I think that is more right than seeing it as murder. That's so black and white. Life isn't black and white. Life is gray. And I would say that the revolution that we have had in bioethics over the last 50, 60 years has been one to move us from black and white into gray areas, which make us all much more susceptible to philosophies and thought processes that are not necessarily going to be coincident with the Catholic faith. This is where the world is at in terms of abortion rates. And this is specifically for Down syndrome. And this is a quote from an article that was published in Human Genetics back in 2021. A series of technical and conceptual developments over the last 4 decades led to the widespread introduction of prenatal screening programs. Okay, great advancement, right? As a result, in countries with optimal, see prenatal screening policies, most neurotube defects and common aneuploidy births can be avoided. Okay, avoided. The language is just horrific because there's only one way to avoid those things. And as we've expanded this prenatal screening, what you may hear from those, especially on the other side, but also from some people who are really genuine, I think, is that really this prenatal screening is important to help moms prepare for the potential for a baby with challenges. That's not quite how NARAL sees it. Early prenatal screening, such as NIPT, is a vital tool for reproductive freedom. By providing accurate genetic information as early as 9 weeks, it allows women to exercise their right to choose before arbitrary legal deadlines imposed by anti-abortion laws take effect. So basically, let's do this early screening and NIPT stuff so that we can get women accessing abortion in those horrific states that have set lower limits for abortion levels and gestational ages. So it's worth thinking about, how did we get here? We are at a point where it's pretty clear that the popular ethos, certainly in biomedical fields, is that all lives are not created equally. I mean, people may not be willing to come out and say that straight up, out front, but it's pretty clear that that is believed very deeply by many people. Some people would call it utilitarianism, emphasizing the welfare of a family maybe, but of the community, of the state. It is founded on quality of life, and it encompasses a duty for people to die. So some may call it relativism, and then some would say feudal care theory is what's really behind this. When a life is feudal, we should really not be in the business of supporting that life. The fact is that very often, and we'll talk about specific examples, it isn't the life that's feudal. It's not, because the care can support the life. What is deemed to be feudal is the outcome of the life. And so C.S. Lewis, I think if you haven't read him, is worth reading, because this is very pertinent for this conversation when you think about the abolition of man. But what ethicists have jumped to is saying that bioethics is a social movement, sort of similar to the teachers in Lewis's Abolition of Man. Gaius teaching how to really take the heart out of a student and leave him nothing with reactivity, with a gut, and with a brain. Daniel Callahan, another noted bioethicist, Hastings Center guy, wrote, the first thing those in bioethics had to do was push religion aside. So this is clearly a war. These people understood this was a war. And these are people that are writing a number of years ago. I mean, this type of language was being used through the 1960s into the 1970s. So how do you see that manifest today? Well, we've abandoned the Hippocratic Oath. I don't know, some people might quaintly think the Hippocratic Oath is still a thing. It's not. Most medical schools write their own oaths now. And they don't talk about abortion and euthanasia. They do talk about some duty to the sick individual, but they talk more about quality of life and the ability to support a good quality of life generally. And there's some data up there just looking at the different oaths that are out there. The new oaths, I treat a sick human being whose illness may affect the person's family and economic stability. I am a member of a society with special obligations to all my fellow human beings, those of sound mind and body, as well as the infirmed. How about the duty to your patient, not other fellow human beings in the context of that patient? This has become formalized, and this is what is taught in medical schools, nursing schools, any kind of biomedical training field now as the ethical pillars that you are to follow. And it's called the Georgetown Mantra by some. It was published by bioethicists at Georgetown. But there are 4 principles. The principles are autonomy, beneficence, justice, and non-malfeasance. Those sound great. I mean, who could argue with those things, right? But you all are probably thinking about those principles in the context of believing in the sanctity of life. There is no mooring in the sanctity of life anymore. What this is moored in is quality of life. And quality of life, I wouldn't even call shifting sand. I don't know what I would call it, but it can move with the wind. And so these principles, if you really think about it, could be used to justify pretty much just about any heinous action that's ever been taken in history. And I think about Nazism in particular. I think these principles could be well applied to Nazism. We as a people are in love with autonomy. We love our autonomy. I mean, that's one of the big ones that we really like. What we need to be thinking about, and these were words from Bishop Barron a few weeks ago on a podcast, we need to be thinking more about theonomy. And that's a God that you are responsible to and need to answer to, and not a self that you need to answer to. But we are totally adverse to that, and we are way far away from achieving that at this point. We are a world of autonomy right now. Judgments regarding quality of life, they're being made by medical providers. I mean, I live with this every day. And across the world where I do counseling and consults with families with kids with difficult prenatal diagnoses, what doctors and physicians define as quality of life is very often very different from what families would define as quality of life. So who's going to decide the quality of life and apply those principles and then decide what the fate is of my child? There are personal biases that go into this. I'm going to show you some data on that. And then ultimately, in some cases, what you get down to is when there's disagreement between parents or families and the providers, the doctors, about what to do, it goes to an ethics committee. And in many places, ethics committees have really become quasi-judicial bodies. And I call it the tyranny of the ethics committees, where they will judge what should be the ethical decision to be made. And that's what the providers will go with. I mean, these are some of the cases that you've seen where, despite a parent's desire to keep a patient on life support, the patient is withdrawn from life support with the support of the ethics committees. So the foundations right now for your bioethical framework are up there. Autonomy, beneficence, non-malfeasance, justice. Those are your medical ethics. Dignity and honesty hopefully would be part of that, but everything is directed towards quality of life, and sanctity of life has taken an absolute back seat. This is the tyranny of the ethicist. And I think this is a great quote. I'll just quickly go through it here. This is from Elie Wiesel, who spent his time in a concentration camp in Nazi Germany, and has gone on to win numerous awards, including Nobel Peace Prizes. But I've always believed that the opposite of good is not evil. The opposite of good is indifference. I think that is incredibly powerful today. But in Auschwitz, I learned that indifference can be as deadly as malevolence. And now in this room, filled with scholars debating the nature of truth, I hear echoes of that indifference. They speak of relativism, of how morality is a social construct, how there are no absolutes. Deny this, eliminate those absolutes, and there is no limit to the evil ordinary human beings can talk themselves into doing. And this goes back to taking Georgetown mantra principles, not based, founded in the sanctity of life, and going into a facility providing medical care. Lord knows what can happen at that point, depending what your definition of quality of life is. These are a couple of other quotes. I'm not going to run through all of these, but it's horrifying what people are actually willing to write and put in print out there. If criteria such as the cost for the potential parents are good enough reasons for having an abortion, even when the fetus is healthy, if the moral status of the newborn is the same as that of the fetus, and if neither has any moral value by virtue of being a potential person, i.e. a non-person, then the same reasons which justify abortion should justify the killing of the potential person. And this has been used by people like Peter Singer to justify that babies born with Down syndrome should be able to be killed after they're born if the parents don't desire to have that baby and it's a surprise. And while I think that's horrific and I hate it, Peter Singer is consistent. I mean, there's nothing magical about going down the birth canal that makes you a person and more human. He is saying it's still not a person. There's some personhood designation I have developed that then we could take this child's life before, but not after. When we decided to write this article about after-birth abortion, we had no idea our paper would raise such heated debate. Why not? You should have known. People keep saying this. The answer is simple. The article was supposed to be read by other fellow bioethicists who are familiar with this topic and our arguments. This debate has been going on for 40 years. So behind your backs, this has been going on for a long time, and it's now just starting to get really fully operationalized. And I would say that it gets fully operationalized with what happens with prenatal screening. So to my journey. So this is me at a press conference back in 2009. And I am there with my daughter, Shay, right here. Here's Shay, here's me. This Trent Franks, he was a congressman. We were called up there and asked to speak on the impact of Obamacare on families with kids with special needs. And that has been significant, and it's been terrible. What I met, though, when I was there is all of these families, some with pictures of their kids, some in their wheelchairs, many of them trisomy 13 and trisomy 18 families. And I looked around at this group of folks and I said, this is not real, because I know, I've been taught all of these babies die by the time they're a year old. They don't survive. These people can't have these kids. And so going around the room there, talking to folks, I said, are your kids maybe partial trisomy 13, 18? Or are they, maybe there's something else? Oh no, Marty, you don't know the literature. I'm like, really? Yeah, you don't know. And I met this woman right here, Barb Farlow, who had a picture of her daughter, Annie. And Annie had trisomy 13, was born in Canada. It was very difficult for Barb to get through the pregnancy without being just constantly asked if she wanted an abortion. She delivered Annie. Annie lived for 3 months, was in NICU for about 6 months. She goes back into the hospital at about 3 months with a respiratory issue. And the family goes downstairs to eat. Annie's on the peds floor. They get called up to the ICU. Annie's now in the ICU in respiratory distress. And they tell Barb and Tim, Barb and her husband, well, we're going to need to intubate Annie if you want her to survive. But if we put a breathing tube in her, she'll never come off the ventilator. And Barb and Tim, young parents, right, are like, we don't want that. All right, well, let's just let her go. Turns out that there were some questionable things that happened in terms of medications while Annie was on the peds floor. And there may have been some medication administration which might have contributed to her breathing issues. But the fact is, on immediate reaction, being given this type of information, a young family had to make a decision like this. And Barb, about 3-4 months later, really didn't feel good about the decision. She started pulling records, and it appeared to her that other things had gone on, which were problematic in Annie's hospitalization. And the long short is she became a great advocate for families with trisomy 13 and 18. She's written several articles I'm going to reference. And as a civilian, non-medical mom who's had a daughter with trisomy 13. Here we go. She and I became good friends and fast friends and spent that day together. And we continued our relationship. Barb and I started working with families from Canada and from the United States. This is back in like 2010, 2009, who were looking to try and get care for their babies, especially kids with trisomy 13 and 18. A lot about trisomy 13 and 18, but I only used them as the example with challenging prenatal diagnoses. So there are others. I don't want you to think this is to the exclusion of other types of diagnoses. But the biggest ones that we're screening for right now are Down syndrome, trisomy 21, trisomy 18, and trisomy 13. And we'll talk a little bit about the screening when we get there. But Barb and I worked on this case in Canada. It was baby Joseph. Joseph was 9 months old. He had respiratory issues. He was not going to survive off the ventilator. He probably had a diagnosis that was going to mean he would die within the next year or so. And Canada refused to support him. They were going to take him off the vent and let him die. And his family did not want that to happen. So they reached out to Barb. Barb and I got together. We reached out to Priests for Life, and Father Frank Pavone somehow got the funds from Priests for Life to send a plane up to Canada and grab baby Joseph out of this hospital in the middle of the night up in London, Ontario, and bring him down to St. Louis. And he got trached down in St. Louis. Joseph ended up going back home with a trach, with home ventilation, and survived about 6 months thereafter and ended up dying. But it was a death at home with the family, and it was time for them that was incredibly valuable and important. But this is sort of where I really started getting involved in this type of work. And then Be Not Afraid came along for me about 14 years ago, dealing with a case at UNC. This is Addie and Allie. They were conjoined twins. Their parents, Jeremy and Risa, had traveled up and down the East Coast trying to find someone that would offer care for their babies after birth and give them a chance. They were joined at the chest. They shared parts of their heart, and it was going to be unlikely that they would do well. So no one was willing to offer them anything other than comfort hospice care after birth. And we at UNC said we would take care of them, and we would offer them care and see what happened. So they delivered at our place. It was the most amazing day because we don't do conjoined twins a lot anywhere. And there were about 30, 40 people in the operating room. The nurse did the timeout. We had Father in there, their parish priest from down at the coast, down at New Bern, who was in the room, had gotten permission from Bishop Burbage to do the confirmation and the baptism. And so we did the timeout. And after the timeout was done, Father says, "Excuse me, could I have the attention of anyone in the room?" And we prayed. And he prayed for the physicians, for the technician, everybody in the room doing the surgery, and for mom and dad and babies. And the kids came out, were born kicking and screaming. And he confirmed them and baptized them in the operating room. It was pretty awesome. But they lived 11 days. I met the director for Be Not Afraid during this time, Tracy Windsor. And Tracy is my hero. When I grow up someday, I want to be like Tracy. Bridget Moore here knows Tracy very well. And she's just a saint of a woman. But Be Not Afraid is an organization I'll talk about at the end here because I think it's something that all of you, I hope, will think about. Because it's a way to try and support families who are in these difficult types of situations. So this is what I was taught about trisomy 13 and 18. And so when I say I had an epiphany, it happened when I met Barb Farlow on that day up in Washington. But these people, these moms told me, you don't know what you're talking about. And I was willing to listen to that. And if you're going to be a good physician, you have to have that willingness to be told you're wrong and go look at your books or do some more research. And I did. But this is what I was taught. It was that here's trisomy 13, 18. Look at all these terrible pictures, cleft palates and all this other stuff, club feet. And look at these survivals. They all, at a year, 5% survival. So why are you wasting your time with this? Just move right along. But then I dug deeper. And this is literature from 1994. I mean, we're talking about now it's 2010. And I've never seen this. But this is literature showing that at a year, trisomy 18 and 13 kids with survivals that are about 40%. It's like, what? I mean, 40%? I mean, nobody who has a survival of 40% gets told that they're going to die and we're not going to do anything for you. No one in cancer world gets told that. So that was absolutely shocking. And the data has just kept flowing over the years. So this is data from Canada. You know, that place that didn't want to take care of Joseph, no friend to kids with trisomy 13 or 18, let me tell you. And these are survivals from Canada looking at a period from 1991 to 2012. And if you were alive at 1 month with trisomy 13 or 18, At a year, 47% survival and 36% survival. Look at all these deaths in the first week and in the first month. What might those be? Well, it could be they have such horrible medical complexities they might die. Yeah, some of them do, but most of them don't. That don't explain it. Could it be that we don't support them? Could it be that we just decide to do comfort care because of their diagnosis and we think it's lethal? And that's what everyone's always said. Could it be that we're hooked on perinatal hospice? And so a lot of kids are going to die. I'll show you some more data about that. Think about that for a minute, though. So if I'd not met those moms, if I'd not seen this data, if they hadn't woken me up, I wouldn't have met this woman. Saskia is 23 with trisomy 18. I met her in England when I was over there doing a talk on trisomy 13 and 18. And, and a lot of parents could have a Saskia, and maybe they wouldn't want to necessarily, but I think a lot of people, if they knew there was a chance, they might. Problem is they don't even know that chance exists generally right now. Other things that have advanced survival for these particular babies, 13 and 18, heart surgeries, 90% of them have heart defects. And what I was always told is you never send these babies to heart surgery because they're going to die. They're going to die in the operating room. It's going to be awful. And then the parents can't see them and they're dead in the operating room. I'm like, really? So here's data that was published in 2019 looking at survivals for trisomy 13 or 18 after heart surgeries. And this lays out different stages of heart surgery. Stat 1 is sort of the easier. If there is an easy heart surgery, it's category 1, stat 1, and the toughest ones are category 5. But most of the kids with trisomy 13 and 18 are stat 1 and 2, maybe stat 3. So if you look over here, what you see is in this database, what happens with trisomy kids and what happens with everybody else. So if you're getting a stat 1 surgery and you're a kid with normal chromosomes, your risk for death is 0.5. So 0.5%. If you're a kid with trisomy, your risk for death is 8%. Okay, so that's like 16 times higher, right? But it's 8%. I mean, the working assumption for a lot of us had been before this data was that this number would be like 90%, and it's not. And then similarly, you see sort of similar splits, 2.2 for a little more complex or 2.4, and then 10 and 19%. So it's not a death knell if you go to surgery with one of these kids. They're challenging, I'm not saying that, and they are more difficult cases. You could see there's a difference in mortality. But it doesn't mean you're sending them off to die if they go to the operating room. And there's been a couple of single center studies done pretty recently looking at survivals for these kids. This is Cincinnati. They're looking at survivals of 50% now for kids with trisomy. This is from Japan, and they're looking at survivals similarly. In this later group, this is an early group with survivals for trisomy 18. Here's a later group, years later, almost 60% there. And the difference is that they're willing to do heart surgeries and they're willing to attend to something else with these kids, which is their airway is often a problem. So they're willing to do things to support the airway, to do trachs if they need to do other interventions that were previously denied, to do interventions that would be done for kids with normal chromosomes. And this is a statement from the American Thoracic Society saying that we should be doing surgery or offering at least surgeries for these kids. This is a landmark statement in this world with trisomy 13 and 18. Everybody's not hip with it, I'll tell you. I mean, I counsel a lot of families and send them the articles, and they go in and they see their cardiologist or CT surgeon, and they say no. And then I say, well, go somewhere else, get a second opinion. Here's where you might be able to go. And that's what we do at Be Not Afraid when we're dealing and counseling with these families. So, this whole notion of things are lethal, or the language we use now is the nice language of life limiting. We don't say your kid has a lethal disorder. That's like persona non grata. Now we say your baby has a life limiting disorder. Last I checked, I think we're all life limited. So I think that language sucks. And nobody in their right mind, and many of us know some people dealing with cancer diagnoses now, no one is going to be told with one of these diagnoses, with these survivals, that they're lethal. That language doesn't come up, but it comes up for prenatal diagnosis and for little babies. But it ain't happening when you're adults. We use other words, and everyone gets the point that you might have a short life. But we don't say that kind of language. And language, as we know in the pro-life world, is everything. The one thing I will say to you, just to be transparent, is that kids with trisomy 13 and 18 have severe developmental delays. So these kids can survive, but they're going to have severe motor and cognitive dysfunction. They do develop. They're not kids that are totally limited and plateau and never develop any further, but they develop much, much slower. So that's something that's important. And some of them do get to points where they can use a walker. Some have gotten to points where they can stand. Language is very variable, but generally it's very diminished. Some of them are able to sign, but the point being that development can occur. So, given all of this, how do we as doctors look at these trisomy 18 people? So surveys have been done looking at this. So if you take a bunch of obstetricians in Australia, New Zealand, and the UK, this is a little bit older data, but it ain't much different now. You ask the question, is T18 a lethal abnormality? There's that lethal word, right? Wow, 85% lethal abnormality. Okay, that's pretty bad. All right, is trisomy 18 incompatible with life? It sounds like the same question, but we have a different answer. It's 54%. So where did we lose 30% of the obstetricians who now say, well, it's lethal, but it's not incompatible with life? And then we get to the money question. Is trisomy 18 compatible with a child having a meaningful life? There we go. There we go. 8% meaningful life. So it's really a quality of life judgment on the part of the obstetricians. Horrible. And obstetricians, there are great obstetricians, and many have really turned their ship thinking about this. But they're surgeons. So surely I think what we could say is that nice guys like me, neonatologists, we're going to be different. We're going to be very empathetic and open to valuing these lives. So let's check it out. Same question. Trisomy 18 is a lethal condition. 83%. Trisomy 18 incompatible with life. 45%. We lost 40% of those docs. So 40% are really saying now, even though it was lethal, it's compatible with life. Again? Not again? Again. Is it compatible with a meaningful life? 15%. So it's not the care that is really the issue here. It's not the care that's futile. It's people judging a life as futile. So, those are really, folks who are very pessimistic, established practitioners. Let's ask residents and nurses, because nurses are going to be better, I'm sure. I really think they'll be better. So let's ask nurses, if you had a pregnancy that was prenatally diagnosed with trisomy 18, would you abort? Delivery room nurses, 71% would abort. 74% NICU nurses, 83% of NICU Children's Hospital nurses, peds residents, trainees, 74% would abort. OB residents, 75% would abort. So you can see pretty well where feelings are. And this is really discouraging to me when they ask about Down syndrome. Pretty much across the board, 50 to 70% of these folks would abort the baby. I want to bring up a different topic, a little bit of a turn here, and talk a little bit about what do we do with babies afterwards, and talk a little about definitions, because I think definitions are important. Words are important here. You'll probably hear a lot about palliative care and hospice care. I would throw in there as well comfort care. Those are the three terms that you hear talked about in terms of caring for babies after they're born with difficult prenatal diagnoses. What is palliative care? Palliative care is care that we give to improve the quality of life of someone that we are actively treating. So we're still treating disease. We have not given up on trying to cure the disease, but we are focused on comfort. And we realize that there are some challenges with this disease. And at some point, maybe the treatments may overwhelm what's going on, and it may not be worth, the orange may not be worth the squeeze. But hospice care says that we are no longer seeking curative treatment. Curative treatment is off the table. Comfort is the priority. So we focus on caring, not curing. Two very different things. But when it comes to infants, these terms are regularly intermingled. There are some good places that have neonatal baby palliative care programs, but there are many that call palliative care perinatal hospice and mix them together. And comfort care really is basically hospice care. But it's a nicer sounding word, I think, to some people. And so in order to try and discuss this with folks, for whatever reason, people like kinder, gentler terms. So comfort care is a word that, a term that comes up quite a bit. So has anyone ever studied this? They have. I mean, and I think this is really important. I think this is a landmark study for understanding what goes on with perinatal hospice, and especially what goes on with babies that are prenatally diagnosed versus babies that are postnatally diagnosed. So diagnosed before birth inside of mom, diagnosed after birth in the neonatal intensive care unit. So what they looked at, this was a study by Barb Farlow, that woman I mentioned to you earlier, Annie Janvier and Keith Barrington. They are neonatologists. And so it looked at palliative care, and it looked at prenatal diagnosis and postnatal diagnosis. And what they found in their review of all the records they looked at was that prenatal diagnosis, palliative care was this: warmth, skin-to-skin care, medications for comfort, and bereavement psychological support. That's it. No feeding plan. And by the way, the medications that we use can suppress breathing, just to throw that out there. Postnatal diagnosis, meaning, your baby's in the NICU for 6 days. We don't know necessarily what your baby's diagnosis is. Everything is being done for those babies. So they may be on IVs, they may have feeding tubes, they may be on a ventilator, they may be getting antibiotics, they may be getting a host of interventions. And so parents then get a diagnosis and they have a choice to make. And not uncommonly, after they've been taking care of their baby and seeing them survive for 6 days in the NICU with support, many will choose to continue support. But that option is not available for most people with a prenatal diagnosis. So what they concluded is, it seems palliative care for children with a prenatal diagnosis is directed to a goal of having as short a survival as possible. Let that sink in. It's basically, how quickly can we expedite the death of the baby? It seems, though, to us, and this is the author speaking, that neither universal imposition of comfort care nor universal intensive care and invasive surgery is appropriate. So that would suggest there really should be some conversation and informed consent and discussion with the families about what the potential plans are. So what currently is typically offered to folks with a prenatal diagnosis is this: it's abortion. Oh, you want to continue the pregnancy? Perinatal hospice. The language used in these presentations is often fatal language, lethal language, and it's not accurate. It's disingenuous. It doesn't reflect the reality of what we know about these kids now. And even if you say not lethal, but life-limiting, that's pretty directive. I mean, I think if I talk to most of my families and say, what do you think if I tell you your baby's got a life-limiting diagnosis? I mean, the wheels spin and it translates as lethal. I mean, that's what most of them are thinking. So it's a nicer way, in my mind, of saying lethal rather than saying, other issues. We're all life limited. And then I think ultimately what we're doing with perinatal hospice for many of these babies, given the data that you all have just seen, is we're delaying the day of death for these babies. So they didn't get aborted, but we're delaying the day that they're going to die. We don't know exactly when it will be, but if we're not feeding them and they're only getting comfort care, hospice care, or palliative care, it's pretty clear from Annie Janvier's work that the outcome is going to be death. The factor most highly associated with a baby never leaving the hospital with trisomy 13 and 18 is a prenatal diagnosis. So what's disturbing to me as a Catholic and a physician is that it seems Christians and Catholics have an obsession now with perinatal hospice. And the pro-life movement in general, I think, has an obsession with perinatal hospice for this group of kids. Granted, we don't want women to abort. I mean, if we can have women avoid the horror of abortion for themselves, never mind the baby, but for them, the known things that happen from abortion, that is a win. And I will take that W. But the answer is not to say, we'll just have the baby be born, give some narcotics, let mom go skin to skin, and wave goodbye to the baby as they gently slip off to the other side. First of all, that often doesn't happen very gently. Sometimes that's pretty ugly, watching that happen. And when you're not informing parents about the opportunity that they could have Saskia at 23, it is wrong. It's not ethical. It is unethical. And I think at this point, we're at a point where what we're doing with perinatal hospice and advocating for it and supporting it, which is what I see at the UCSSB, at the SSB website, and multiple diocesan websites, is just wide open advocacy for perinatal hospice for moms who have challenging deliveries, and a willingness of us as Catholics, our clergy, and other Christians to adopt and accept the language of life-limiting and lethal. It's not true. And we need to really do some introspection, and we need to think about this. Father Ted over at the National Catholic Bioethics Center says, if we stipulate that our children need to be sufficiently perfect and not so badly off, we offer a conditional, disfigured form of human love, driven first by our own interest, instead of that sacrificial parental love that every pregnancy betokens. Yes, all right, that's great. But how about saying the baby could survive? It doesn't have to be perinatal hospice. So what do we say to parents then? What are doctors saying to parents that are making these decisions? And here's the data. This ain't me, it's data. You should consider abortion 60%. Your baby will die before birth, 94%. Your baby won't live more than a few months, 88%. Your baby is lethal or incompatible with life, 93%, and on and on. Your child will be a vegetable. That's wonderful. And then lots of conversation with families about these babies destroying their marriages or really adversely impacting their other kids, which the literature shows is not true. The Down syndrome literature is really clear on this, that families with kids with Down syndrome, their other kids are unbelievably well adjusted and benefit from having a sibling with Down syndrome. So these are the things that parents have to be willing to overcome. And I think it's worth looking at some of the actual quotes from some of these folks. I'm not going to read all of these because they're just horrid. But I found out my daughter had full T18 when I was 18 weeks pregnant. OB said 3 times he wanted to terminate. He said, no one survives, at best only a few hours. Why would you want to give birth to a baby that's going to be no use to society? An OB asked me if I wanted to burden my other kids with a sibling. Another doctor told me these children lacked all will to live. They were without a soul and unable to experience being alive. Let me take you back to like 1939. Who was it that ran the programs that sent the mentally deficient and Down syndrome babies and children and adults into the gas chambers? It was physicians. It was doctors. It wasn't Hitler who came up with that. It was all medics. A GYN asked me if I had any children. I told him I had a 9-month-old with full trisomy 18. Oh, he said, so you're just like counting down the days. This I got last week, the last quote here. So a mom that we sent to Be Not Afraid. And the doctor said to her, why would you want to continue this pregnancy? The only thing keeping your baby alive is the placenta. Yeah. But you get a young mom who's sitting there and she's told this, and what is she going to take away from that? Oh my gosh. Yeah, that would be the case for every other baby. Glad you sat through that class. Yeah. So why do physicians do this? These are guesses from me. I don't know for sure. Many of us still can't get over the fact that some of these kids live, and we were taught forever that they don't live. They do live. Some of them can live. Not all of them. Can't save everyone, but many we can. Many have not seen a child with trisomy survive. Some do not believe that the mental deficiencies of kids with these disorders, and again, I'm talking about trisomy 13, 18, but this would apply to a host of other prenatal diagnoses that are less common. These mental disabilities are not worth living with. And here you go, you could throw in your Georgetown mantra and your ethical principles: beneficence, autonomy, justice. We shouldn't live with mental deficiencies like that. Some personally view severe disability as equal to suffering and pain. Beneficence, non-malfeasance. Some docs, I think, really believe they have to foresee a future with a challenging kid, with lots of financial things that parents can't see, especially young parents. So they're heavily biased. And I've had people tell me to my face that we should not waste resources on these babies. So what do the parents think? This is a survey of them, and 89% said that their experience with their kid was super positive. In families where a child lived longer than 3 months, 50% did admit that their kids experienced more pain than another baby would, and that their lives were more challenging. 98% said, though, that the child enriched their life. 82% felt the child had a positive effect on other siblings. And I think this is the money question. So if you had another pregnancy where you were prenatally diagnosed, what would you do with the pregnancy? And 83% responded, continue, or I would never have any more prenatal testing. I'd take what I was given. So I think that's pretty powerful. 9% weren't sure. 8% said they would terminate the pregnancy, abort the pregnancy. So my daughter has a question for everybody. You know, we went through a period for a long time with Down syndrome where we did not offer them health care. They were extremely discriminated against after they were born. We would put them into institutions, and their life expectancy was very short. Have we learned anything? Until the 1980s, Down syndrome was kind of life limiting, you know, to be quite honest. Life expectancy was 8 to 12 years in 1949. Disability rights groups are really the ones who changed the world for Down syndrome people. It wasn't doctors. Doctors were still totally on board with allowing these babies to die and doing nothing for them. Medical literature, even through the 70s, is still using terms like defective mongoloids. That was like a term. And then we got kinder, just like lethal went to life limiting. We went from defective mongoloids to just plain old mongoloids. We had the baby doe case in '82, which was in Indiana, where a family elected to let their baby with an esophageal atresia, a potentially surgical fixable condition, die in the hospital, basically based on the testimony that was approved by a judge of an obstetrician, actually. And then we were delaying surgeries for kids with Down syndrome into the 90s. Kids who were good candidates for surgeries for their problems, we were not operating on them. We were discriminating against them. So there's statements like this out there which kind of make me chuckle. And this is sort of the bias that's out there. Survival of infants with trisomy 18 is not improved with aggressive obstetric or neonatal care. The natural history of trisomy 18 is well studied, and our results are in keeping with the findings of others. The fact is, we don't know anything about these disorders. We spent so much time killing these babies that we don't know what their longevity is, what the arc of their survival is like, what their long-term medical history would look like. We just haven't had enough of them survive. It's really only the last 5 or 10 years that a number of places have started to step up, and we're going to offer care for these kids. The fact is that Down syndrome families, just like trisomy families now, are absolutely committed to offering care for their kids. And they have one resource really that they could go to, which doctors hate, which is the internet. They can go to trisomy support groups, and similarly for other prenatal diagnoses, and hear stories about kids who have survived and find doctors who are willing to operate on and support their kids. So it's just sort of staggering that after everything we've went through with Down syndrome, that we really haven't necessarily learned a whole heck of a lot. What we have done, though, and recreated, is the tyranny of the self-fulfilling prophecy. I have a ton of power. If I tell you as a young parent, your kid has a lethal or life-limiting disorder, guess what you're going to do? And I offer you abortion as the first option, pretty good chance that you're heading off to Planned Parenthood or to an abortion clinic. We have that power. When you say something is lethal as a physician, we can make it lethal. And so the more we say it's lethal, the more lethal it is. Because we don't supply any care, then people die. Wow, they were right. So this is where we're at now with trisomy conditions. And that ship we need to turn. It left the port a long time ago, but we need to do something about it. But this is not going to help. So a little bit about NIPT, non-invasive prenatal testing, prenatal diagnosis. A mom's blood has fragments of the baby's DNA. You can analyze mom's blood for those DNA fragments. NIPT is now recommended. This screening, prenatal screening, is recommended for all mothers in the United States since 2015. In 2012, it was just for older moms, but now it's for everybody. So every mother is offered this. It analyzes fragments, looking for DNA from specific chromosomes using probes. There's several different tests. The sensitivity and specificity, for those of you who are statistics type people, are way better than tests we were previously using to try and predict things like Down syndrome and other trisomy conditions. But sensitivity is really just being able to predict that disease is present. Specificity is really being able to say that in a bunch of specimens, there's no disease. Sensitivity, specificity. What you care about as a patient is the positive predictive value. The positive predictive value is the number that basically says, how likely is it that my test, which came back positive, is a real positive? That's what you want to know as a mom or as a parent. So PPV is the proportion of positive tests, true positives, over true positives plus false positives. Important to know that even though these screening tests are advertised everywhere as sensitivity and specificity of 98, 99%, I mean, most people who don't know stats look at that and say, wow, that's an awesome test. I mean, it can predict for sure what's going on with my baby. Because diseases have different amounts of incidence in different populations. Trisomy 13 and trisomy 18 specifically are fairly rare. 13 is the rarest, maybe about 1 in 12,000 births is a trisomy 13. Trisomy 18 is maybe 1 in about 8,000 births. Down syndrome depends, but maybe somewhere around 1 in 1,000. So the most common is Down syndrome. So these tests are more accurate when a disease is more prevalent in the population. So more accurate, better PPV for Down syndrome, crappy PPV for trisomy 18 and trisomy 13, and really crappy PPV for younger moms, because these things, these genetic disorders, are less common in younger moms. So what does that translate into here? Let's look, because there's calculators out there. Everybody loves a good calculator. So what you can do, and this is the one we use at UNC, you can go in and plug in. On the left, I've got a mom who's 24 years old. On the right, I've got a mom who's 38 years old. Both of them are gestational age in weeks, about 10 weeks when they had their test done, okay? Same. They had panorama tests, so both of them are panorama. But you could see on the right, the mom with trisomy 13 and trisomy 18 and trisomy 21 screening, the PPV goes up to 59% for trisomy 13, 82%, 92% for Down syndrome. So 92% is fairly high likelihood that your positive test is a positive test, right? 59% is basically a coin flip. So you may as well just flip a coin. I mean, it's the same as doing this test. But then when you look at the young mom and she gets her test back, and many of us in this field see this all day long, mom gets her test back, she's 24 years old, her screen is positive for trisomy 13, I'm thinking about aborting my baby. The PPV on that test is 14%. I mean, the chance that it's real is 14%. But she's thinking about heading down to the abortion clinic now because she's 24 and she goes out and looks up trisomy 13 and sees all those pictures I showed you earlier about all these kids with clefts and all this other stuff. She don't want that. So those two tests really show you the difference in the positive predictive value. And that is key and something that most parents, most moms are never told about when they get these tests. So up to 13% in the literature of OBs, I think it's probably higher, but up to 13% of OBs surveyed regard the NIPT test as diagnostic. It is a screening test. It is not diagnostic. So what you're supposed to do when you get a positive test is your OB or your midwife or whoever would recommend that you go get a diagnostic test. A diagnostic test is an amniocentesis or a CVS, chorionic villus sampling. But 13% of OBs are looking at that test as diagnostic and telling and counseling and working with parents based on that. The big issue is now with abortion limits. Many people, just like that NARAL quote earlier, are feeling that they need to push moms out based on a diagnostic test if she wants to think about abortion. Because if you have a limit that would be at 16, 18, 20 weeks, whatever your state may have, you don't have much time. So diagnostically, yeah, we'd like to get there, but the NIPT is the NIPT. So, and many OBs don't really, this is in the literature as well, don't really discriminate that sensitivity and specificity from positive predictive value. The other thing that's unclear is how PPVs are being reported by some of these companies. And I think it's a little bit shaky what they're reporting to moms because their algorithms that they use are not publicly released. They're proprietary in terms of giving mom a PPV. So the thing that would be really fascinating to know, and I think it would be a little bit scary, is what is the literature on moms who get a positive NIPT for abortion? That literature isn't out there. And I think there might be reasons it's not out there. I mean, it's not been published. It's not really been talked about. So even if we were ready to go ahead and do NIPT well, and talk to moms about it fairly and let them know everything that we're doing. Because I'll say a number of moms, when they get these tests, they're getting it really just to determine the sex of their baby. They haven't heard all these other gene screens that are going to go on with that sample, and they want to know earlier what the baby's sex is. So that's why they get it. And then they get a result back that shows them that they pop positive on a screen for trisomy 18 or 13. So, but even if we were doing better with that, what are we seeing with obstetricians' abilities to really perform counseling? What do they say? You know, we can easily do the blood test. That's not hard to do. But providers don't have time for the counseling to do everything that would really be required to do good informed consent for this. Patients get information overload and they just shut down. So how do you really talk to patients about this, even if you want to do it right? It's challenging. And then genetic education is not that good. So OB residents, people who are in the maternal fields, they're not well educated on what all these tests mean. And the tests are only getting more complicated because now we're doing different types of screening beyond just looking for trisomies, looking for other genetic disorders. And that becomes super challenging in terms of how you counsel a mom. And those tests have even greater inaccuracies because they're even less common. So we're not set up well to do this. And when you survey OBGYN residents, this was from 2021, 42% said their genetics education and residency was not, they felt, sufficient for practice. That's a pretty terrible statement. So I think where we're at, whether it's willfully or not, is we're working in a 21st century version of the eugenics world. I mean, we're not mandating everybody get screened, but we are routinizing it. I mean, it's hard for a mom to come in when she gets hit with all these things we're going to do. Do you want to get your genetic screening? And a lot of folks just sign stuff. And they aren't really looking and seeing what they're signing off for. We understand genetics now, is what people say. I mean, I think we heard that during COVID as well, and I don't think that worked out really well. But, and we're finding out it's gonna work out less well and less well. But we don't understand genetics that well. We really don't. They say we're focused on real diseases. No, we're looking at Down syndrome, we're looking at trisomy 13, 18. Every one of these patients is different and unique, has different medical complexities. So you're not looking at specific diseases, you're looking at a whole person. We're seeing now that there's a big drop-off in people getting diagnostic testing. The literature's clear. Less people are getting amnios and CVS. Back to my further point, people now are using this NIPT screen as diagnostic, which should not be happening. And to be fair, the obstetric governing bodies say it shouldn't be diagnostic. It's a screen, but people are not following that. Never mind what patients might do when they go out. Abortion rates for the NIPT screen disorders, you know, what we're screening for, 80 to 100% is what the abortion rate is after a real positive screen. So, I mean, I don't know how we say this isn't eugenics. Because abortion is generally the result of this screening process that finds positives. And the conditions we're looking for are all mental and physical handicaps. Yeah, they have some medical disorders. They might have a heart disease, but they also have severe mental and motor impairments. So that sort of seems like what we were doing back in the 1930s, or in this country even earlier, when we said 3 generations of idiots is enough from a Supreme Court justice. So lack of informed consent is just horrific right now for the test and after the test, talking to moms about what might be possible for the baby. And the bottom line is this screening does zero to improve the health of the baby. Doesn't do anything to help the baby. All it does is supposedly help the mom prepare maybe for the delivery of a baby with challenges. But most of these babies can actually be taken care of in reasonable hospitals, at least initially. They don't require a level 4 NICU like mine. So there just isn't much that these tests are able to do. So the question becomes, where do we go from here? And what do parents deserve? And I think at a bare minimum, parents deserve informed consent. So telling a parent prenatal diagnosis that a condition is incompatible with life and your options are abortion or comfort care or palliative care, that's not informed consent to me. It's informed consent when the option to perform our duty to stabilize and evaluate a patient like any other patient is actually informed consent. And that's just not often talked about. Again, back to Saskia, this is how we would get to patients who are 23 with trisomy 18, which is kind of a rarity now, but I think there could be more of them. So what societally is the answer? Could churches be the answer? And I would say no. I say the churches have failed. We've failed. I mean, I don't even think most of you in this room really kind of understood what this problem was before you came in here. We know a lot about pro-life issues. There are lots of different battlefields where we fight the pro-life war, but the church has not even, they're not on the battlefield. I wouldn't say they've abandoned the field. They haven't even recognized the field. They have just accepted the language of medical professionals saying that there are life-limiting disorders, and that's so sad. And let's do perinatal hospice, and that's what USCCB says. And that's just not ethical. It's not in the face of the data that we have. So I think what clergy need to do, and we need to do as faithful, is challenge this language, the language of what I call the utilitarians. Lethal and life-limiting, just stop talking like that. I mean, we need to get rid of that. We need to resist the appeal of people, utilitarians, who would say, oh, but compassion and autonomy, we should really be allowing this. And I think we don't know if that course, perinatal hospice, for instance, is the right course till we meet the baby. I mean, the baby will tell us a whole lot of things that we will never know in utero. I mean, and that's not true for all of them. And there are some babies where perinatal hospice is very appropriate, where we just can't do things for them. But the data would suggest that there's a lot of these babies, maybe 40, 50, 70%, who could be alive at a year of life. Now, maybe you don't want a baby with mental and physical handicaps, but there are other options which we as pro-life people should be willing to offer beyond perinatal hospice. Killing the baby shouldn't be the next best option, just because we avoided an abortion. And then we have to understand the bias in the medical community. You saw it on the slides here, but there are tremendous biases towards trying to predict what a good quality of life would be, the paternalism that sometimes we exercise as physicians, and I would include myself in that. And I would say, honestly, I was one of the people who, before I met Barb Farlow on that date back in 2009, was telling people, oh, I'm so sorry about your trisomy 18 diagnosis. Your baby's going to die. Let's just do comfort care. But I think we've had so much literature come out now to tell us otherwise. To not recognize it is, it's just dumbfounding to me. So churches maybe not the answer. Hopefully they could be the answer. Legislation. Can we legislate our way out of this? I don't think so. Because our culture is what it is. And it's really problematic. We do have 15 states where you can't abort a baby for fetal anomalies. It's not bad. 35 states allow abortion for a fetal anomaly at some point during the pregnancy. Some all the way through pregnancy, right up till birth. Some up until specified age limits. And then when you break down the states as far as the people who in theory are on the pro-life side, meaning the GOP, 23% of the states with exceptions are totally GOP controlled. That means the legislature and the governor. Not good. An additional 16%, 6 states, have GOP-controlled legislatures. They don't have the governor. Only one state, Kansas, of all of those, attempted a bill restricting abortion for fetal anomaly, but it was vetoed and not overridden by the legislature, but they tried. So I understand the political realities are real. I mean, I've been a part of this fight and worked with the folks down at downtown in Raleigh at the legislature trying to put together decent legislation for this. But politicians, like clergy, they need to stop using the language of medical professionals that would tell us that we can accurately predict life-limiting conditions. We can't. You can't. Anything that I would have told you was life-limiting 10 years ago when I was doing this, there clearly is literature of those kids surviving out to 2 and 3 years, any one of them, whether it's absent kidneys, whether it's anencephaly, whether it's trisomy conditions or other things. In North Carolina, what do we got? So we have SB 20. It was passed 23-24 legislative session. But an infant with a life-limiting disorder can be aborted through the 24th week of pregnancy. So we built into that legislation these things, which I fought for, and they put them in, which I think are great. It was basically trying to hold physicians to an informed consent standard. And you can read them all up there. They all make sense, making sure parents get the full amount of information that they need to try and deal with this challenging pregnancy. But the fact was, we could not pass abortion legislation in that session without an exception for fetal anomalies to 24 weeks. The Republican majority would have fallen apart. It wouldn't have gone through. We wouldn't have had legislation. And while we put in all that great counseling language in the legislation, there's absolutely no ability to enforce it. So it's all nice stuff, but we can't enforce it at all. It's not being tracked at all. But so what about the medical establishment? I'm sure they'll bail us out. Yeah. They have failed to answer the bell, no shock. So from the FDA in 2022 on these tests, we are aware of reports that patients and healthcare providers have made critical healthcare decisions based on results from these screening tests without additional confirmatory testing, no diagnostic testing. Pregnant people have ended pregnancies. Well, this was Biden FDA, pregnant people. Pregnant people have ended pregnancies based on the results of genetic prenatal screening alone without understanding the limitations of the tests. So this was the FDA sending out a warning letter. And the response from the ruling body in OB world, the American College of OBGYN, was basically to reissue their prior guidance for what to do with this screening, which says do diagnostics, but it was basically a reissue. I mean, that was about what it was. And I don't think it's really necessarily changed the landscape a whole lot based on some of the literature we're looking at. This is the pediatric side, because they're always better, right? Not so much. This, I think, is such weak sauce, I can't even begin to describe. A lot of people have celebrated this because what the American Academy of Peds at least said was that it was okay to offer some of these trisomy babies medical intervention. Some. But what they said was survivals were 10 to 25% at 1 year. Not true in the people that are really working hard to take care of these kids. It's much higher. Consideration of neurodevelopmental impairment and quality of life now plays a prominent role in deliberations, meaning, translation, it's not lethal anymore, but what we have to think about is the neurodevelopment. Do we want severely neurodevelopmentally delayed kids? On the basis of contemporary data, we conclude that exclusive comfort care remains a morally acceptable choice that ought to be offered to all parents, which I just don't understand how you say that. First of all, they've got survival numbers wrong. But if you have survivals of 50 or 60% at 1 year, I don't know how you can't say that we'll at least attempt to stabilize and evaluate babies after birth, that would be our ethical and moral requirement as physicians. And that is not at all, obviously, what they're saying. So for families who choose to continue the pregnancy, this diagnosis alone should not categorically preclude offering therapies that could potentially prolong life. And then last, pediatric clinicians might be asked to support expectant parents who are considering pregnancy termination. Although limitations in access now exist, making travel necessary or introducing other obstacles for some families pursuing this option. So pediatricians should make sure they are engaged in the states that have abortion regulations that might be 12, 14, 16 weeks to make sure parents get access to the abortion that they might want to pursue. I mean, to me, this is just horrifying. I mean, the American Academy of Peds is what it is. I mean, they're not a pro-life organization, but as an organization that's supposed to be protecting children, that's their mission, that is not at all what's happening here. So what is the answer then? And honestly, I think whether you're secular or if you're religious, I think the answer is love. I think that's the only answer. I think what we have to realize is, back to what I said initially, find a way for us to get back as a community to a community that recognizes that we have acknowledged dependence on each other, that we need to support each other, that the weakest and the frailest among us may not be the weakest and the frailest, because we are judging those by our standards. And those are our ways, not his ways. So I think that the next best answer is figuring out how we really partner with parents on a journey with a life-limiting condition. You have to remember, when a parent gets this news, the child's a loved family member. The pregnancy doesn't go away. You've just destroyed that family's prediction of the future, all their dreams and hopes. Many times, parents are offered abortion that day after they are told their child has a life-limiting or lethal anomaly. For many, this forces you to confront, gee, is my love a conditional love? Did I really love my baby? Now I have to reject my baby because my baby's physically or maybe mentally deficient? So I think these are difficult cases. I mean, I'm not diminishing that they're difficult for us as perinatal providers and docs, but very often we make this whole experience worse for families. We make it more traumatic by using the language that we use, by not understanding the attachment that mothers may have, by suspecting or suggesting that maybe another pregnancy could replace the one that they have. There's so many ways that we have traumatized these families. And so the personal pregnancy experience is really difficult. Hard for parents to go and talk to other family members about this. Hard to go out and look on the internet and see lethal, life-limiting, and all these terrible pictures. Hard to read stuff about why would you not abort this baby? Why would you bring such a terrible, troubled child into this world? And then you've got to deal with the medical system, which is fractured, which doesn't have people that necessarily are the best to really start relating to families dealing with these problems and walk with them as they make this journey. So I think there's one organization out there that does answer the bell, and that's Be Not Afraid. Be Not Afraid is that group that I met over Addie and Allie's bedside with Tracy Windsor. It's a training organization now. We are training organizations around the country to be good at this care. We offer trauma-informed care that is evidence-based, that is associated with physicians, which can help and support parent care coordinators who work with the families. We walk with these families on this journey. We try to identify them prenatally, and we walk with them through the birth and through the post-birth, whatever that may bring. Whether it brings death, that may be possible, or it brings life. And we help support them through that whole process. Because the fight is not only prenatally. Once these babies are born, I think sometimes the fight is even tougher postnatally. I think some people think once you get through the delivery and all that, we get to the other side, we're in the NICU. It doesn't get easier there. It sometimes even gets a whole lot harder. The Catholic teaching on life and disability is core to what we do at Be Not Afraid, but we take everybody. We love everybody. We take care of people of all faiths, and we take care of people with no faith. And we've taken care of people around the world, actually, not just in this country. What we're doing right now is we have 14 organizations around the country that are working with parents that get identified as having prenatal challenges with diagnostic screening of some sort or another, a difficult prenatal diagnosis. And we support all those organizations. Those organizations are all staffed with people who are BNA trained. The BNA training, probably about a 4 to 6 week course, which is modular, includes videos, includes reading, includes live presentations and videos, includes a heavy dose of trying to work with people who have been traumatized. Because the day you get this diagnosis, whatever it is, the trauma begins. I mean, the world is falling apart on that day. And someone needs to be extremely sensitive to that, how you had power taken away from you, how you need to be able to put back in a place where you can make decisions and feel you have some control over your life. And this organization does that. We have nobody in North Carolina right now doing this. We've talked with the diocese here in the past. We've talked with Birth Choice in the past. No takers. It's been a little while. I think, the folks at BNA have sort of just got tired of knocking on the door. We would love to be knocking on the door again, and have people here that would be willing to take this up, that would want to take the training and be willing to walk with these families when they get identified. I mean, how potentially something like that works is we ask that there be at least one person who is committed to a project like this. It's obviously not full-time. Everybody doesn't have a slate of patients they're dealing with. But if you have 1 or 2 people that you're following, that can be a handful when you're trying to stay in touch with them every day or every couple of days and walk with them through all their appointments, through all the ups and downs that they go through. And so at least one person is good. It's better to have 2 or 3 people who would be interested and go through the training. Our next training is going to be in February. So we are revamping how we're doing this. And the training, we do have a fee. I mean, it's $1,000 per person taking the training, but it's well worth it for the people that are the beneficiaries of those people who get trained. So, oh no, come back. So that's my pitch for Be Not Afraid. I'll leave you with 2 things and I'm done. I'm sorry, I'm sure I ran over. So I love this passage, which summarizes everything that I could ever want to talk about. If I just had one slide, this would be it. It's from a guy named Morris West, writing in Clowns of God. I know what you're thinking. You need a sign. What better one could I give you but to make this little one whole and new? This is Jesus standing at a home for children with Down syndrome at the second coming. Christ has come back. Everybody doesn't recognize him. Some people do, but he's back. And he's standing there holding a young child with Down syndrome. He says, I could do it, but I will not. I am the Lord and not a conjurer. I gave this mite a gift I denied to all of you, eternal innocence. To you she looks imperfect, but to me she is flawless. She will never offend me as all of you have done. She will never pervert or destroy the work of my Father's hands. She is necessary to you. She will evoke the kindness that will keep you human. Her infirmity will prompt you to gratitude for your own good fortune. More, she will remind you every day that I am who I am, that my ways are not yours, and that the smallest dust mite whirled in the darkest spaces does not fall out of my hand. I have chosen you. You have not chosen me. This little one is my sign to you. Treasure her. And I will say that the little infants and the big folks and the young adults and the adults now that I've had the opportunity to work with some of these most challenging prenatal diagnoses, it's been just an unbelievable privilege because I think they have taught me more about myself and more than I can ever do for them. They have taught me something super important and something super special. And what they have taught me how to do better is to love. Thanks.